While examining the foot, I need to be systematic. I will first of all introduce myself. Then I will reconfirm the findings from the history, check for any orthotics or support which the patient is using, and comment on that. If the patient is having generally a flat foot, I need to do a heel raise test. While in a cavus deformity, I need to do a Coleman block test. I will first of all look to the patient, examine the patient's shoes. If there is insoles, I will describe that insoles. I will also confirm and sneak to the for the any problem in the hand which can point towards rheumatoid arthritis or hereditary sensory motor neuropathy. I will comment by any scars or callosities or muscle wasting. For examination from the front, I will ask the patient to stand and see the knee alignment or the clawing. I will check for the weight bearing position, check the medial border and the arch, check the lateral border and confirm the weight bearing. Check for any callosities on the dorsum of the metatarsophalangeal joints. See for any callosities and deformities like a Hallus valgus deformity. From behind, I will check for the calf. Check for the hind foot varus or valgus alignment. Too many toe signs can be positive in a valgus foot, where laterally there will be more than 1.5 toes visible. And check for any scars or incisions for previous surgical intervention. If the patient is having a plano-valgus deformity, I will do a heel raise test, in which I will ask the patient to stand on his tiptoes. A single heel raise test can be done for a tibial posterior insufficiency, and I will proceed with a Coleman block test as well at that moment. Once I have done the examination while standing, I will ask the patient to sit. While the patient is sitting, I will check for any pain at that moment and check for bony prominences and as well as soft tissue prominences. I personally start testing bony prominences first by palpating the medial malleus, go towards the ankle joint, and systematically go to the lateral aspect with the tip of the fibula palpated. Then I concentrate towards the palpating the fifth metatarsal base, checking for tendon readiness at that moment. Check for the sinus tarsi region and palpate it. Concentrate and go downwards towards the metatarsal, fifth metatarsal. Then I concentrate towards the medial aspect by palpating the navicular bone, going distally on the head of the talus, and go systematically towards from medial to lateral towards the tarsometatarsal joints. Then I move down and palpate all the tarsal bones. Then I concentrate towards the soft tissue component of the examination, that is Achilles tendon, tibialis anterior, tibialis posterior, peroneus longus, sinus tarsi. Then I concentrate on the back of the foot and check for the plantar fascia, palpate it, check for any tenderness at the medial aspect of the heel. Then I examine the metatarsal fat pads and palpate all that. and then I concentrate towards the special tests. Once I've inspected and do the palpation, I will start doing the range of motion. I will hold the talus, the hind foot and use the hand as a cup and try to move move the foot. I will ask to start doing active exercises and add passive if needed. I will do the dorsiflexion, plantar flexion, inversion, eversion, along with supination. While doing these examinations, I would prefer to do palpating the muscle. So while in dorsiflexion, I want to palpate the tibialis anterior. While doing plantar flexion, I will check for the peroneus longus and the flexors. During the inversion, I will check the tibialis anterior. During the eversion, I will check the peroneus longus. I will also specifically test for tibialis posterior and peroneus longus. When I've done these tests, I want to check for some special tests. Before the special test, I need to check the neurology. So I prefer to check the L4, which is the medial aspect of the calf, L5, which is lateral aspect of the calf, the dorsal aspect of the foot for the superficial peroneal nerve, the first web space for the deep peroneal nerve, the medial aspect of the cephalus nerve, and the lateral aspect of the sural nerve, and the plantar aspect of the foot for the tibial nerve. I will then do the special test. The first test which I will do is a silver squat test. So silver squat test is basically check whether we have Achilles tendon tightness or soleus tightness. So basically, I will start with the knee flexed and try to dorsiflex the foot, and then I will try to extend it. If the with the extension the dorsiflexion is reduced, this means that there is a gastrocnemius tightness. Gastrocnemius arising proximally. If it is similar, this means there is Achilles tendon cord tightness. I can do a Thompson test, which is basically the patient will be placed prone and I will measure the angle of dangle, which is the reduced the angle in which the angle of the foot is increased. I will ask the patient to be prone and try to squeeze the calf. When I squeeze, there will be a movement, that is plantar flexion of the calf, because of the gastrosoleus component and Achilles tendon. If it's negative, the angle of dangle would be increased, as well as on squeezing, there will be no plantar flexion. I can do the external rotation stress test when I feel when I would check for the syndesmosis, and it will be tenderness on the and that is called the external rotation stress test. So I'll try to external rotate the foot at dorsiflexion and check for if there is any tenderness on the syndesmosis. I can do a Hopkins test, which is a squeeze test. I will try to press the tibia and fibula together with my both arms and ask the patient if there is any tenderness at the syndesmosis. I can do the anterior drawer test. So anterior drawer test is done in plantar flexion of 20 degrees for anterior tibiofibular ligament and dorsiflexion for the calcaneofibular ligament. I will grasp the tibia one hand and the heel in the other hand and try to compare the instability both sides. I can do a jack size test in a child in which I try to dorsiflex the big toe and check if the medial arch is recreated. A grind test is done for the hallux rigidus, in which I try to palpate and try to move to and from motion of the metatarsophalangeal joint and see for any tenderness. The coronal black test is a test which is done for the patient who have cavus deformity. The basic principle is to check if the hind foot, if the cavus deformity is forefoot driven or the hind foot driven. So if the deformity corrects, this means it's a forefoot driven deformity, and a correction of the forefoot itself will improve the hind foot position. While if it is continued to be remain the same, this means the deformity is hind foot driven. So the basic principle is that I will ask the patient to stand on a block with, and then I will try to allow the first ray to drop. The heel will be on the block, and when the first ray is allowed to drop outside the block, it will go into plantar flexion and the heel valgus will improve. Heel varus will improve and convert into normal valgus. If it is positive, this means that it is a forefoot driven deformity, and any intervention in the forefoot will improve the deformity itself. On the other hand, if it does not improve, this means it's either hindfoot deformity or the deformity has been so long that there is now hindfoot deformity as well correlating with the problem. In any plantar fasciitis, cavus deformity, and planovalgus deformity, it is very important to talk about the Achilles tendon problems.